Thank you. I really appreciate it, and thanks for everybody coming. Thank you, Dr. Cascone. It's been a real pleasure working with you and your team to make this happen. The way it came about was I attended a Board of Ed meeting not intending to speak. I just live in Holmdel. I've lived here for 30 years. I've been blessed to have my children go through the school system, and in a couple of years, my grandson's going to go through the school system. So I'm really appreciative of everything that everybody does here. But they were talking about violence in the school system at the Board of Ed meeting and speaking about behavioral issues, looking at behavioral modification techniques and internet activity that the kids might be looking at. And so I just thought, well, maybe I could bring this up because I've heard from a good number of physicians that it affects there's a cognitive issue to it. So what I did was, and I'm also involved a little bit because I started a support group in New Jersey called New Jersey Lyme and Associated Diseases Support Group. And that group is simply to help people that have Lyme disease or co-infections meet others so they can interact with them. It shares information. And most of all, give them some encouragement and hope, because without hope, I think everybody's in a pretty dark place. And it can be a pretty devastating illness. So my family has gone through it, and I just would like to see folks being able to be diagnosed much earlier. And what happens is that some of the illnesses that you think a person has is really Lyme disease or Bartonella babesiosis, those related co-infections, and they mimic other illnesses. And it doesn't happen until much later, until an acute situation becomes chronic, that it becomes known, and then it's hard to treat. So this effort is to share information about those illnesses and how they mimic other illnesses, some things that you might want to consider as you're looking at a child, and how to handle that, and so that when that child, as they develop, they can get treated much earlier. And that's the whole hope, to raise awareness here. And so I thank you for coming here and for your time. And with that, I'm just going to read some of the introductions for the psychiatrists, each doctor. They're all these are the top doctors in the country that are dealing with this illness. And it's really a privilege to have each of them here. So I'm going to keep the bios brief because we have about 2 hours. And so let me start off with that. And I think I have lost Dr. Marke's bio. Dr. Mark, I don't know what, here it is. I'm sorry. Okay. Dr. Jane Marke is a board-certified psychiatrist with an integrative private practice concentrating on Lyme disease in New York City. Before training in psychiatry, she trained in internal medicine and is board eligible as an internist. Combining her interest in psychiatry and internal medicine, she did fellowship training in psychosomatics and consultation psychiatry, and her practice has always had a focus on patients with medical illnesses. Over the course of years, she was drawn to integrative treatment, became board certified in complementary and holistic medicine. Becoming ill with Lyme disease when a junior in high school herself, she was not diagnosed properly until 2009, after many misdiagnoses, and quickly learned that Lyme was more prevalent in her patient's population, and she realized and began making diagnoses in those folks and also some of their children. For 15 years, she's practiced and has almost 100% patients suffering from psychiatric illnesses as a result of tick-borne diseases, vector-borne diseases. She's currently the founder and co-chairperson of Mothers Against Lyme, having herself not realized that her own 2 children were exposed to Lyme disease in utero, and realizing how mothers are carrying the weight of the burden helping their children while often being ill themselves. So she's optimistic that an army of mothers can have an impact. And I think that's very important. What she has here is that, children can contract it without a tick bite or a mosquito bite or a flea bite by getting it in utero if the mother has it. Second speaker will be Dr. Greenberg. And Dr. Greenberg is board certified in psychiatry with a private practice in Summit, New Jersey. Dr. Greenberg is known for her expertise in the diagnosis and management of complex psychiatric problems in children and pediatric psychopharmacology. For many years, she has served on the teaching facility or faculty at Columbia. Dr. Greenberg is an author, researcher, lecturer, co-producer of an educational film, and creator and host of an award-winning television cable show, all related to children's health. Dr. Greenberg brings her 40 years of experience to topics that range from adolescent suicide and pediatric bipolar disorder, as well as many psychology aspects attributed to Lyme disease. And we're talking about suicide and also homicide acts. You've seen in the news how a lot of school systems, Holmdel's been blessed not to experience it, but it's happening around the country. Dr. Bransfield is the third speaker. He was board certified by the American Board of Psychology and Neurology in Psychology, and is a distinguished life member of the American Psychiatric Association. His primary activity is an office-based and private practice in psychiatry in Red Bank, New Jersey. In addition, Dr. Bransfield is the past president of the International Lyme and Associated Diseases Society, which many refer to as ILADS, and also the ILADS Educational Foundation, and the New Jersey Psychiatric Association. He is a clinical associate professor of psychiatry at Rutgers Robert Wood Johnson Medical Center and the Hackensack Meridian School of Medicine. He has authored numerous publications and has been active in political advocacy on an international, national, state, and also local level. So without that, with all that said, I should say, I'm going to turn this over to Dr. Jane Marke, and the psychiatrist will take it from here. So thank you.
Is this working? Yeah, okay. So I'm going to give the first talk while I have a psychiatry practice. The 2 doctors following me are going to talk about the psychiatric problems in much more detail. I'm going to talk a little bit more about why it's so important. So school staff really need to become familiar with Lyme because, you're where the kids learn, but also you are potentially where they're exposed to Lyme, out on the playing fields, in the parks, on the football fields. You teach basic health, and Lyme can be a part of that. You can also identify at-risk kids in many areas, and I'd like Lyme to be added to the area of at-risk kids. I really think knowledge is the key to making sure that kids get diagnosed early and that they don't get it. Why is this not moving? Okay. What this slide should show you is that 22% of the total cases of Lyme are in children under the age of 18. And the reason I want to show you that is, well, it proves that my high school math came in handy because I figured that out from that. But because Lyme is just as common in children as it is in adults. And while I think everybody here can say that they know an adult with Lyme, we don't think of that about children. The magnitude of the problem. The CDC has surveillance criteria, and these are cases that are diagnosed and treated. And so they say that there are 95,000 new cases of Lyme a year that occur in kids out of a total of 476,000. Insurance data is even higher. It's 6 to 8 times as high. But if you look at epidemiological data, that predicts that there are about 1.9 million cases of late Lyme by 2020, which would make 400,000 under age 18. So it's really very widespread. And, whoops. And as you can see from this map, you are the epicenter. You beat out Connecticut and even Maine. Whoops. Wrong way. Of these late Lyme patients, they're almost all cognitively and psychiatrically affected. And Lyme presents mainly neuropsychiatrically in kids. While they do have physical symptoms, they're much easier to dismiss. So what is it like to have Lyme disease? All of the kids that you would be seeing in school have late Lyme disease. They're very tired, they have musculoskeletal aches and pains, and they have a high level of sleep disturbance. A lot of that is easy to write off in high school kids. It's even easy to write off in younger kids. But they have an extremely high incidence of depression and anxiety. The kids that you see in school invariably have late Lyme, and that is symptoms that occur over 6 months after a tick bite. The physical components are often written off. My own daughter, for instance, went to bed crying and clutching her legs every night for years. And every doctor told her that she was having growing pains, something which I really didn't understand existed, and which I don't think really does exist. So how do kids get Lyme? Well, you all know that they get them from tick bites, but they also get them congenitally. It's passed mother to fetus, and it is also passed through the breast milk. Dr. Jones, who has a pediatric practice, or had a pediatric practice of Lyme disease, out of 5,000 kids, 5% of them were congenital Lyme. So first I'm going to talk about tick bite Lyme. But the important thing here is that the spirochete that enters you when you have a tick bite makes its way into the central nervous system very quickly. It gets in there, before 2 weeks are over. And then the brain has an immune response and tries to get rid of the bacteria. So the immune response is one of inflammation. However, slide went on. However, it doesn't actually get rid of the bacteria. That's why we need antibiotics. But what it does do is it causes inflammation in the brain. So most of the problems that we see neurologically that come from the brain are not due to the organism itself, it's due to the way the body handles the organism and the way the body fights it. So of our late Lyme patients, they're almost all cognitively and psychiatrically effective. And in kids, you're going to see neuropsychiatric symptoms very quickly. We call it late Lyme when the symptoms last for 6 months after a tick bite primarily. There's no definition of late Lyme when it's congenital. And in late Lyme, you see that the symptoms are musculoskeletal with high levels of sleep disturbance, depression, and anxiety. I keep going the wrong way, I'm sorry. Okay, and because after the tick bite, the Borrelia get into the brain so quickly, prevention and very early treatment is the key. So what to do? Well, before kids play in the grass, it's really important that they have tick repellent on them. DEET, picaridin, and oil of eucalyptus are considered good. DEET lasts longer. Most parents prefer something that they think of as not a chemical, but if you're using something like picaridin or oil of eucalyptus, it has to be changed very frequently. They need to be sprayed about every 2 hours. So kids should have extra in their backpack, and schools need to come up with a way of dealing with reapplying it if the kids are out in the fields here. Okay. And when returning from a place that's infested with Lyme ticks, which is pretty much all over New Jersey, it's important that kids take off their clothing as they come into the house. There should be a basket where they can dump their clothing. One can treat the basket with permethrin, which is a chemical that you can buy online or buy in a hardware store. It's for use on clothing, it's not for use on skin. And the most effective thing to do to rid the clothing of ticks is to put it in the dryer. So you put it in the dryer right away, or you throw it into the hamper lined with permethrin. It's important to do tick checks. There's a tick check song that's easy to find on YouTube, and it comes in different versions for different ages, but it enables kids to learn how to do them on themselves. Because as they grow up, doing tick checks is like brushing your teeth. It has to become a habit that the kid can do on their own. Okay. What to do when bitten by a tick? Well, the most important thing is to remove the tick properly, and that's with a clean tweezers, and it really should be a needlepoint tweezers, and send the tick for testing. Treatment should begin immediately, even before you get the results of the testing back. You can stop the antibiotic in a few days. Testing just takes about 4 days to come back if you get the tick tested. And, don't wait for the results. Just start. I don't know why I'm having trouble advancing this. This is a do-it-yourself tick kit. It's really easy to make. I suggest that you can give handouts to the parents of requisitions from several labs. They can fill them out. You can keep them in an envelope, an addressed, stamped envelope with a filled-out requisition, and send the tick off immediately if the tick is found that, in the nurse's office, that the kid has a tick attached. And I believe that these can be carried everywhere. I have one that I just carry in my purse. I give them to people to keep in their backpacks. And that way you're always prepared. Lyme is pretty undertreated in kids. People are easily able to write off the symptoms, and the guidelines that people will find when they look at the CDC website really aren't very helpful for kids. So suspect Lyme in anybody that has flu-like symptoms and it's not flu season. Suspect Lyme in school kids that have any of the issues that are going to be discussed in this presentation, which are things like an abrupt change of personality, behavior, or the onset of any psychiatric disorder, or the onset of ADD. And that just went too. And here's a typical problem with the diagnosis. We're all taught that a bullseye rash is typical of Lyme disease. But a bullseye rash is very rare, and these are all examples of rashes that are Lyme rashes. And the one that's a bullseye rash here is on the little baby's cheek. And that's, I got a phone call from a friend of mine who had a 3-month-old baby, and 2 doctors refused to treat because the rash was under 5 centimeters. And the CDC says that the rash has to be bigger. 25 minutes, I'll do it. Okay. Diagnosis. The CDC on their website has surveillance criteria. And that's not criteria that should be used for diagnosis, and it's widely misinterpreted, so it widely is used. And what's wrong with using the CDC criteria? They're surveillance criteria. They're reported cases, and they use only one strain of Borrelia to test for, and that's a lab strain. It's not what we're seeing. There are over 100 strains out there. And they require a two-tiered test, a screening test, and then another test. And from that test, they have removed 2 of the most important antibodies that are specific for Lyme disease. And they removed those antibodies because they wanted to save them for a vaccine. So that test is not very good. Specialty labs are better. They're more expensive, but there is one that does take insurance. They include the antibodies that the CDC has left out, and they skip the screening test, and they look for many strains, and they also look for co-infections. Ticks are like tanks or organisms. They carry 1 million organisms. We're all aware of Lyme, but there are a lot of other organisms. I particularly like IGeneX, as do many of my colleagues. And they recently did validation testing, and it was very important because they showed that they had 100% specificity with no false positives. And that's a complaint that people have. Oh, specialty labs, everybody comes out positive. And they were 90% sensitive, which was really wonderful at all stages. The diagnosis should really be made clinically. And here again, if you go to the CDC website, it's not very helpful. It says things like the rash has to be 5 centimeters, and on a little kid, it's not necessarily 5 centimeters. It says there needs to be joint swelling, and it leaves out all of the neuropsychiatric symptoms. I think I went 2, okay. Congenital Lyme. So this has been known about for a long time. It's been known about since 1985. It was first published. 2020, the CDC put it on their website, and they now have a fact sheet on pregnancy and Lyme disease. And we have a study done by Dr. Charles Ray Jones, who had a pediatric Lyme practice, and 80% of these children had cognitive problems and learning disabilities. And 9% had autism, and I think that might even be higher. It's also transmitted. I'm a little worried about going 2 at a time. The NIH also says that there is placental transmission, and it is on their website, but they have done no research on it, and there's no money funding it. So the impact on the newborn is learning defects, learning disabilities, autism, mood swings, fatigue, and congenital defects. The autism prevalence has been increasing markedly in recent years. I think you're all very aware of that. In general, it's 300%, but it's 500% in kids who have no intellectual disability, and I think that's very important for people to understand and recognize. And looking at some statistics, autism increased 340% between 2000 and 2018. And it seems to me that Lyme increased pretty much the same. It's hard to get hard figures on this, but in 2000 there were 410,000 identified cases, and in 2018 there were projected to be 2 million. And again, that was 2 slides. And this is a map showing the overlap of autism and Lyme. And if you put these 2 maps on top of each other, you can see that the states that have a high incidence of autism and Lyme are the same. And to make that more clear, these are the top 15 states for autism and the top 15 states for Lyme. The first column is Lyme, the second column is autism. I'm sorry I didn't label them. But look at the overlap. It's pretty remarkable, and there's not much research being done on this. There have been studies on treatment of children with autism with antibiotics. And this is one study that shows that 5 children who had Lyme disease, when treated, their autism improved markedly, just with antibiotics. The CDC says that Lyme does not cause autism, but they removed bands 31 and 34, which were the 2 that I said were specific that they were holding for a vaccine. Dr. Bransfield here did a study from asking the parents of children who were diagnosed with Lyme and diagnosed with autism and tested for Lyme, and found that 45 of 48 who were negative by CDC standards were positive when they put back the antibodies that the CDC had taken out. So that's a very impressive group. So pediatric Lyme. The kids have behavioral issues, sensory integration disturbances, rage, visual disturbances. So they're often identified with behavioral problems. Compared with real behavioral issues, kids who really have behavioral issues, they have a lot more shame and guilt about their outbursts and about the things that they do that get them into trouble. They're not sociopaths. You can't really successfully treat the Lyme behaviorally, the kids behaviorally. Restorative justice doesn't do well with these kids because they know that what they're doing is wrong and they really can't help it. They need to have their Lyme treated. Inflammation causes all of the symptoms listed here, and all are seen in Lyme, and we're talking about neuroinflammation. The inflammatory state of Lyme is an excitatory state, one of glutamate excitation. And glutamate is the neurotransmitter that balances off GABA, which is the one that is relaxing and pulls us down. Glutamate is excitation. And so it seems really obvious that things like anxiety and insomnia, bipolar disorder, would result. It doesn't seem as obvious that the kids would be depressed, but that is also associated with inflammation. These are a list of the psychiatric syndromes. I'm not going to go into depth about them all because the 2 doctors following me are. I just want to mention a few things that I really care about. And one of them is encephalopathy. And that just means a disorder of the brain. And this looks very much like ADD. So when you have somebody developing ADD later in school, something's causing the onset. The same thing with abrupt onset of OCD. And they often have derealization and depersonalization, which is a feeling that they're not quite real or the world isn't quite real. The kids also have autism to a large extent and hyperacusis, where sounds and lights just seem to be too bright and too noisy. So I think that just looking out for those is very important. I also wanted to say a word about the depression, because there's depression and then there's anhedonia. And what I've been seeing in my Lyme patients is this one, anhedonia, where it's the absence of any emotion. It's a kind of a numbness, with an inability to enjoy anything. And I think a lot of people would say that it's better to feel sad than to feel absolutely nothing. Anxiety is also ubiquitous, but when children get anxious, it often makes them irritable and angry. And so it's not really identified as anxiety, it's identified as a behavior problem. The intrusive symptoms are pretty widespread, and they're things that come into the brain that you don't want. They're not hallucinations, but there are intrusive thoughts that pop up. And I mentioned musical hallucinations because that's how my Lyme started when I was 17. I couldn't stop singing a Pepsi-Cola commercial in my head. And if there's one thing that you don't want to hear all day long, that's it. And that kept me from falling asleep. And intrusive thoughts, like from out of nowhere, a religious kid would be having blasphemous thoughts. Kids have thoughts of, oh, I'm going to kill my younger brother or sister. And they don't like these. They have personality changes. They often seem to lack compassion and empathy. But the kids are not sociopaths. They're just so wrapped up in their own symptoms that it's very hard to feel for others. And they have a great loss of identity and relationships. So it all needs to be dealt with. What should schools do? I think schools should teach and do tick checks. On the younger kids, it should be made into a routine and planned for and treated as any expected transition. Teach children what the ticks look like and how to check their bodies. Send home materials to the parents, telling them what you've taught the kids and having them do it. Teaching the kids how to treat clothing and how to keep it separate. And again, there's this wonderful tick check song on YouTube that should be used from a young age, and for high school, it's a rap, so it's perfect. It's very age appropriate. At parent-teacher conferences, whenever behavioral issues come up, you can talk about the possibility of Lyme disease. Parents that are seeking diagnoses from a developmental pediatrician or a clinical psychiatrist for ADD or oppositional defiant disorder, this is when the school can say, you might bring up with the pediatrician or the psychiatrist the biological roots of whatever it is. Maybe you could look for Lyme. You could share the videotape of this conference. It's important to make the school grounds safe. This can be done with tick tubes, and it can be done with sprays. And if you put up warning signs, it's a reminder to everybody. You can make school trips safe. You can find out about where the kids are going and whether ticks have been cleared, and you can give the parents handouts before you go to an area with ticks, and you can have protocols for checking. You can help teach parents how to talk to a doctor about a tick bite. Please treat my child now. Don't wait for the results of a test. No, one dose of doxycycline isn't enough. Parents need to be supported in dealing with the medical profession who are following guidelines that really only have to do with surveillance. And you can get rid of ticks. There are towns that have gotten rid of them, and I've listed them here. They all have websites explaining what they did. Fire Island has done a really good job. Martha's Vineyard's done a really good job, and they do it over and over. So my take-home message is that you've got to consider Lyme disease as a possibility in every child who's presenting with emotional problems and learning disabilities. And schools need to be safe places where the kids can be safe. You can add Lyme education to your health curriculum. It can fit into a number of subjects. It can fit into different subjects for different age kids. Nursing and behavioral evaluations should consider the possibility. And schools can teach parents. You can send pamphlets home and handouts for what parents should do. You can teach the parents how to have an impact on the community. You can get them to go to civic board meetings. You can encourage that. You can encourage the children to do that. And please remember that Lyme kids with behavioral problems are not bad kids. They're not young sociopaths. They just need treatment. So get everybody active in the community. I think you can teach kids to do tick checks and tick counts. And they could get community service or science project service for doing this. And remember that the grown-up Lyme kid has pretty much lost a childhood. And most of the kids that come to me come at around age 16, and they've been sick for many, many years. So thank you. Did it? Okay. Dr. Greenberg is next.
Okay, let's see if I'm any better at this. Well, maybe not. Okay, tell me how to do this. Doug, how do you go forward? Okay. And when I want to go forward, which one should I press to go to the next slide? Okay, super. Okay. Should I hit those arrows? Should I do it that way?
Get your mind remote back there. It seems to be working better.
Just a minute for technical difficulties. Great. Okay. So anyway, I'm Rosalie Greenberg, and I'm a child and adolescent psychiatrist, and I practice in Summit, New Jersey. And I was born in Brooklyn, as many people can tell from my accent, but we really never knew much about ticks. And then I moved to New Jersey, I don't know, in my 30s or something. I still didn't know much about ticks because I'm not very outdoorsy. But in the past 10 years, my patients have taught me a lot about concerns about tick-borne disorders. And that's why we're here today. It has totally made me revise my thinking about medicine, mental illness, and many different things. And I'm far from a fanatic, but hopefully I can convey to you what I have seen and why this change in my thinking, and actually why we're here today. Okay. So, and I don't have any financial relationships or anything, and I'm not going to discuss medication off-label, which means that it's not FDA approved, but we're not going to really go into that. What I would like to do is talk to you about the mental health of our kids. And we know we're in the middle of a mental health crisis. I'm going to go through Lyme disease statistics, talk about Lyme and mental disorders in adults, then how applicable is it to kids, and talk about co-infections. Because when you have Lyme, you often have 2 or 3 other infections as well. Okay. Oops, that's not the next slide. There it is. This slide says that 1 in 6 kids in the U.S. between the ages of 2 and 8 has a diagnosable mental, behavioral, or developmental disorder. That's scary. I mean, I don't know what else to say except we're talking about down to 2 years of age. And you can't pick up a paper, you can't pick up the Times or the Star Ledger at least once a month. You're seeing some big article about anxiety in our kids, or depression, or the increase in suicide. So we're living in what I consider a very scary time, and we need to be able to think, what can we do to intervene in this? Because this is a very bad cycle. And one thing that we know, half of mental illness that's going to be chronic in adulthood begins before or by age 14. And 3/4 begins by age 24. Well, what are we saying? We're basically saying that if we want to prevent adult chronic illness, mental illness, we really need to intervene, and we need to intervene early and in childhood. That is crucial if we want to make a difference. And if you go through the other mental disorders that exist, or that are diagnosed in kids today, and these are statistics from a few years ago, and we know that a lot of the problems have increased. Here, almost 10% of kids had ADHD in the United States, more than 7% had anxiety or behavioral problems, and more than 3% of kids between the ages of 3 and 17 had depression. And we all keep reading about how depression, especially depression in young girls, has been increasing. And also how much anxiety has been increasing. As I said, look at the Star Ledger from the last few months. It's there all the time, and it's real. And Dr. Marks talked about autism spectrum disorders. Well, when I trained back in late 1970s, early 1980s, I like to say with the dinosaurs, but they really weren't there then. You only saw 1 in like 10,000 kids that had autism, true autism. And I remember during my training, I only saw 1 really autistic kid, and that was at a therapeutic nursery. And now, we know, New Jersey, we have this study came out from Rutgers just a few weeks ago, and it shows that the rate of autistic spectrum disorders in our kids is like 1 to 35. So 1 out of every 35 kids shows elements of this autism spectrum disorder. You've got to say, what is going on? And I'm not saying that I have the answer, but I am saying it is a crisis. And then let's look at youth suicide. It's not just an American phenomenon. Since 2010, there has been an increase in suicide attempts among children throughout the world. And we know that suicide, I used to give lectures on suicide around 20 years ago. And I would always talk about how it was the 3rd leading cause of death in young people. Because young people, thank God, usually don't die. The most common one was always accidents, and then there were homicides, and then the 3rd cause was suicide. Well, that's changed. And now suicide is the 2nd leading cause of death. In kids between the ages of 10 and 14, especially, that's the age that's affected. And New Jersey, and if you look at New Jersey statistics, we all know that COVID didn't help our kids. And one study did, actually, this was in Canada, it wasn't the US. But basically, they looked at the 5 years before COVID and then that first year of COVID. And the suicide rate clearly increased. The number of suicides increased during that year of COVID. And of course, that social isolation is a major issue during these teenage years. And if you look specifically in New Jersey, the kids between the ages of 10 and 19 during these pandemic years have accounted for a larger percent of the total group that suicided, as well as the number of kids have actually increased. And I think we're all very much aware of that. And as I said, this is the 10 to 14-year-old age group that's very vulnerable. Why? We can speculate, but they really are. And studies that have looked at children that have killed themselves by suicide, have 90% or more of them have a diagnosable mental disorder, which really means if we can recognize things and intervene, hopefully we can make a major difference. And you have to remember, suicide statistics are really, suicides are underreported, and especially in a little kid. I can think of one of my guys, I call them guys. Anyway, she was 6 years old, and she was playing with her friends, and she said, I think I want to run into the middle of the road and get hit by a car. Well, her friends, thank God, told her parents, and who called me, and she ended up in the hospital. But if she would have just ran and gotten hit, probably would have been a car accident. So we really don't know all about the rates of suicide in young people. And the thing that has been a major problem that I think we'd all agree on is the increase in number and the ease of access to firearms. Boys have always had a higher rate than girls in successful suicide. That's one way of describing it. Probably not the best words, but part of the reason has been that the boys have always used more lethal methods. Well, now firearms are more available, and so we've got more accidents because of them, and we've got more deaths because of them, and especially in the younger population. Okay, so I'm giving you all these things about how sick our kids are, and I think you guys are on the front line, and the longer you've been teaching, the more likely you are to have seen kids that are multidimensionally impaired or struggling. So how does Lyme disease come into this? Well, Lyme is endemic in New Jersey. It's all over the place, okay? And 25% of the cases, and that's an approximate, Dr. Marke said 22 or 23% in the statistics she showed, but whatever, approximately 25% in a given year of the portion of new cases of Lyme disease occur in children and adolescents under age 19. Now, if the most recent statistic was there are 476,000 cases of Lyme in the U.S., that math translates to 119,000 kids in a year. And remember, it's a disorder that's underdiagnosed. It's more common in boys, especially between the ages of 5 and 14. And if you think about it, it makes sense. Little boys are the ones who are more likely to be rolling in the leaves where the ticks hang out, or crawling through the grass and playing with their friends. And the classic rash is often absent. So if you're looking for the bullseye rash, if you look at a textbook, it will say that 60 or 70 or up to 80% of the cases of kids with Lyme and adults with Lyme have the target rash, have that bullseye type of rash. It's not true. And generally, it's less than 50%. I can tell you that the majority of my practice has ended up being kids with tick-borne disorders. And very few of them, a very small percentage of them, have come to me with a known history of Lyme. Okay. And Dr. Marke brought out a very important thing. Part of what happens with these kids is that since symptoms are not necessarily so specific, it's easy to dismiss them. So she talked about how her daughter had the pains in her legs, and I was telling her about someone I know that didn't sleep through the night for the first 3 years of his life. He even wound up getting sleep studies. He saw more doctors than you can imagine, and more specialists. And then when he was 3, he said, "Mommy, my back hurts. My leg hurts. It's hard to sleep." Took him to the doctor. The doctor said it was growing pains. That's absurd. Okay, you can't, as a parent, if you know something's wrong, you got to keep pursuing it. And growing pains you do get. I mean, it's not that it doesn't occur, but you'll get it more in the teenage years because maybe they've grown 5 inches, but their muscles and tendons and everything haven't exactly stretched enough. But not a 3-year-old. Okay. Now, when we talk about Lyme, we say neuroborreliosis. That's a term for neurologic Lyme. Lyme is caused by a bacteria. And the bacteria in the United States is most common is called Borrelia burgdorferi. Okay? And why kids seem to get infected more in terms of their central nervous system, okay, as opposed to the adults with the peripheral nervous system. So the adults may say, gee, you know, my fingers are numb, my toes are numb, or whatever. But in kids, they're more likely to have neurocognitive and neuropsychiatric symptoms. It is much more common than people realize, and that's why we're talking to you. Because you've got to think about this, and most people don't realize it. Okay. And part of why the central nervous system gets affected, of course, kids are bitten, they're closer to the ground, closer to where ticks are, and they're more likely to get hit, you know, bitten on the head and neck, which is just closer to your brain. Okay. And often what happens is the neuropsychiatric symptoms are misdiagnosed or just not recognized as related to tick-borne illness. Okay. And so what happens with neuropsychiatric or neuropsychological symptoms in Lyme, you know, in an adult, if they get a change in behavior, you're going to know it. You worked with Charlie for 5 years. Suddenly he comes in acting very differently. Well, something's up. But a child's a work in progress. So, you know, kids go through all these different stages of development. So maybe he thought he was going to be a genius and now he's just smart or something. You know, I mean, everybody has their own trajectory. So the regression, though, is going to be harder to recognize if that occurs in a kid. Because kids will show regressive behavior if they haven't slept at night, if they're hungry, or if they're getting sick. And kids also have multiple body complaints. You know, just ask a school nurse, how many headaches and stomach aches does she see each week? And the initial symptoms with Lyme are more like a virus. So, and that's why Dr. Marke said, think about it. Like, if you have somebody presenting with what looks like the flu in the summer, could that be Lyme? And that's very important to think about. And I believe the more common and more subtle manifestations of Lyme in kids is in the neuropsychiatric, the neurocognitive sphere. And that's why you need to know about it. There was one study that looked at kids that presented with Lyme that presented to a neurologic clinic. And there was 96 kids, and they looked at the most frequent symptoms. Well, the most frequent symptom was headaches in 71%. How many kids do you see with headaches? I mean, you know, that's so nonspecific. Yes, it is one of the symptoms. But then the next common one is a facial palsy. And that's the weakness on one side of the face, you will see it. If you ask them to smile, the smile will be uneven because they can't lift the lip, or they can't close their eyes all the way. And if you're lucky, it's called a Bell's palsy. And if a kid's lucky, they'll get the Bell's palsy. Because most pediatricians, when they see a Bell's palsy, they will think Lyme. So that's really a blessing in its own way, if you get that. But the other symptoms, I mean, you can get all these other neurologic symptoms, blurry vision and carpal tunnel and even Guillain-Barré. But there's not that much work that's been done in kids. But there was one study that looked at 20 children and was looking for, does Lyme cause cognitive issues? And these were kids with chronic Lyme. And they had a control group. And compared to the control group, these kids had more deficits in auditory attention, visual attention. So of course it's going to look like ADD in the classroom. Also, they had deficits in working memory and auditory tracking. Working memory is like taking one of those SATs or whatever. You read the paragraph, you keep those important facts up here, and then you go and you answer the questions. And as you see that, you'll go back to what you held up there. But these kids have problems with working memory, so it's not there. So they got to go back and go back to the original again to try and answer the question, which shows you how much longer and how much harder academic tasks will be for these kids. And the truth is, you can get multiple types of cognitive issues with Lyme in kids. And, you know, one of them, what is it? Word finding. I have this 3-year-old who's very smart. And she said, Mommy, I want, it's black, you know, like chocolate. She wanted an Oreo. This kid's very smart. She knew Oreo. She couldn't remember it. And that's what happened. The teacher called the mother and said there's something going on with her because she can't find the right words. We see that in adults, but you can see it in kids too. Okay, so these kids can show all different types of difficulties. And often cognitively, the two things that I look at that go along with Lyme and tick-borne illness is processing speed and working memory, as I described. Okay? And if you're lucky, you have a kid that was evaluated years earlier with the child study team. And if you suddenly see a significant change in those two measures, wonder about Lyme. Because many of my kids that I see in my private practice are very bright. But I see working memory at 3%, 5%, 18%. And these kids are often above average IQ. And processing speed. So think about this. They're sitting and listening to the teacher. It takes longer for the information to get in and for them to think about it. So, of course, the teacher is not slowing down because their thinking is slower, so they're going to miss things. It's very easy to see how a kid can have ADD or look like ADD after a tick bite. And if you have a kid that had ADD in the first place, it just it doesn't always, but it can get even worse. Okay, and these are the things you've got to think about. And it can affect their ability to do math and reading, etc. Okay, now, the one issue that we're all, I think, very much concerned about is suicide. I mean, this is a national problem, but it's a local problem. And many people in the field of Lyme noted that those with Lyme often seemed more depressed and had a lot of suicidal thoughts. Well, you know, is this real or is this just a practice, you know, where you happen to do your studies or whatever? Well, Brian Fallon, who is a psychiatrist at Columbia, who runs that center, paired up with Michael Benros, who is in Denmark. And the Danes keep excellent records, excellent health records. Whenever you want to do a health study and get a number of years, they're the best place to look. So what they did with other investigators, they looked at records of individuals that had been diagnosed with Lyme, but that also had contact with a hospital system. So that could mean they were inpatient hospitals, they could have gone to the outpatient clinic or one of the clinic satellites. And so they reviewed almost 7 million records. What they found is approximately 12,000 individuals were diagnosed with Lyme disease in the group. And when they looked at the group, and what served as the control was the rest of the people, the other 6 million and whatever, was the comparison group, because they didn't have Lyme. And what they found is that those with Lyme had higher rates of mental illness and a 42% higher rate of mood disorders. So that's interesting because that goes along with what I'm telling you, is noticing that a lot of these people get depressed. And it's not just searching to get help. I think it's also their biology and their immune system. And those who had Lyme were at higher risk for suicide attempts, and suicide. They had a higher proportion of suicide. And the more you had Lyme, the more you kept getting it, the more likely you were to have a mood disorder and to be at risk to make a suicide attempt. Suicide did not increase with the number of infections, but these other things absolutely did. Now, one of the things when you look at the study, I told you in the United States, the cause of Lyme most frequently is a bacteria called Borrelia burgdorferi. In Europe, there are two others that are more common, Borrelia afzelii and Borrelia garinii. Names you don't have to remember. But the point is the one that we have in the United States is a much more potent inducer of an inflammatory reaction. And, I mean, that's the buzzword in medicine, isn't it? Inflammation. You can't pick up anything without reading about inflammation in heart disease, in, all neurologic disease, in psychiatric disease. In psychiatric disease, inflammation is very much associated with mood disorders. So, the question is, since we have the more inflammatory one in the U.S., does that play a role in mental illness? And what about in kids who develop chronic Lyme? Do they have that increased risk? Well, the study by Fallon and co-authors divided up the groups that they had that had depressive disorders, and they divided up into 10-year spreads. So from age 0 to 9, 10 to 19, 20 to 29, etc. Okay? And when they looked at the group that had mental disorders, they found that almost 40% of the group that had mental disorders were 19 years or younger. Also, a statistic that just really bothers me is those diagnosed with Lyme before the age of 10 had the highest risk for later suicide attempts. And here we are talking about teenage suicide, and New Jersey, ticks are endemic. You've got to wonder. And the highest rate of mood disorders were in the 10 to 19-year-old age range. And if you go back, like I said, there's not much done in terms of psychiatrically with kids and Lyme. But if you go back and look at that study that was done at the neurology clinic, 38% of those kids actually had what would be neuropsych or neurocognitive problems because they were irritable, they had malaise, they were labile, decreased interest in play. That's a little one who's depressed and had attentional issues. So it's there. It's not what they meant to study. The most common symptom was headache, remember, 71%. But the next most common actually is in the neuropsych, neurocognitive range. Okay, and then if you go back to the other study that looked for cognitive issues in these 20 kids compared to a control group, they gave the parents questionnaires. Okay, these are kids with chronic Lyme. And they gave the kids questionnaires. And they found that 40% of the parents and 40% of the kids agreed that they had had suicidal thoughts. So, yes, this is a very, very, very small group, but not so out of whack given what we've seen in big adult studies. And which leads me to two thoughts. One, that neuropsychiatric symptoms in kids who with tick-borne illnesses are often misdiagnosed, and also that neuropsychiatric symptoms are probably the most common manifestation of Lyme disease in our kids. And you guys are on the front line. Okay, and a study looking at kids who had congenital Lyme. Again, there were a bunch of mothers who had Lyme, and so those with congenital Lyme, and this is taken from Dr. Jones, was mentioned, you see a lot of them wind up having difficulties with irritability, sensory hypersensitivity. The lights bother them, noise bother them, the clothes bother them. There's much more that they're struggling with, as well as depression and suicidal thoughts. Okay. So, and potential symptoms of Lyme. Okay, I'm just going to do it this way so we have it. Lyme is like syphilis. Syphilis was called the great imitator. And Sir William Osler, who's a very famous physician, said, he who knows syphilis knows medicine, knows all of medicine. Because syphilis can present with just about any type of symptom. Well, people refer to Lyme as the new great imitator because you can see just about any type of physical or mental symptom with Lyme. And with these psychiatric issues, I mean, I've seen kids with every single one of these disorders. Kids who have the sudden onset. There's one actually that we published in the literature. A kid who was fine, he was doing great in school, very smart, A's. And then suddenly he starts thinking the cat is the devil and wants to kill him. And this came out of the blue. And then he had a variety of distorted hallucinations and delusions. And he was treated with multiple antibiotics, hospitalized 3 times psychiatrically. The doctor said that this kid has schizophrenia. But he actually wound up having Bartonella. And I'll show you how it was picked up a little later. But that is one of the co-infections. It's a bacterial infection. Okay. Well, okay, but if you think about this, so we know infections can precipitate psychiatric symptoms. How often are psychiatric symptoms precipitating the result of infections? What I did is I took my practice. I reviewed 3 years of cases. I had 69 kids, and I basically looked how many had evidence of tick-borne exposure. And with those that I found 80% of my patients. Now, I have a very specialized practice because for years I specialized in pediatric bipolar disorder, mood disorders. So that skews my practice. But this was kind of outrageous to me. And so then what I did is I looked at 27 of my bipolar kids because my newer bipolar kids often, I found tick-borne disorders. So I said, wait a minute, I got kids that I'm calling manic depressive that have had it for 10 years. Do they have it? And I went back and checked it, and sure enough, I found many previously undiagnosed tic disorders. So when I went through my bipolar kids, at least 75% of them had positive testing, blood testing, but were also confirmed by a specialist that they had Lyme disease and other tick-borne disorders. And that's very important because Lyme is a clinical diagnosis because the tests are lousy. Okay. And we know the increase in autism spectrum, as we've discussed. Okay. You can get all types of anxiety disorders, especially if you get a kid with an intense separation anxiety. Please consider tick-borne illness. I see this all the time. It's totally irrational. The kids may be afraid of somebody dying, but they're also saying, I don't know why, but I can't go to school. as well as sudden onset of obsessive compulsive disorder, or maybe they have panic attacks. Like I said, it can cause anything. And the main problem we have, or one of the problems that we have with tick-borne disorders, ticks are like a dirty needle. You know, it's like ingesting something from a cesspool into somebody. So you're getting multiple bacteria, you're getting viruses, you're getting other toxic things at the same time with that one bite. And that then confuses the symptoms. That's part of why the symptoms are so different in everybody, and affects how you treat them and what the person's going to respond to. The two most common co-infections are babesia, which is a parasite that's related to malaria, and that's associated with a lot of anxiety. The other thing is Bartonella. Bartonella is a bacteria that we learned more about during the AIDS epidemic. We thought it was in immunocompromised people, but that's not necessarily true. So, and Bartonella, you'll learn over time, you'll hear a lot more about that, because it's going to become a much bigger player the more we learn about that in terms of psychiatric symptoms. But Bartonella is the one infection that you might be able to see without a microscope. And I say that because if you look at this slide, you see those lines. Those are called stria, stretch marks. They're like what women get during pregnancy as their bellies extend and you get these red lines. Well, Bartonella, if you're lucky, because again, this tips you off that something's going on, you'll find these stretch marks. But you'll find them in weird places, on the back, on the arms, on the legs, even on the breasts. And that kid that was diagnosed as schizophrenic by a number of people, it was when somebody actually saw that he had these stretch marks that said, oh, maybe he's got Bartonellosis. And that's what they checked for, and that's what he had. And actually, once he got treated for that, it took a while, but the kid was able to be off all his psych meds and go back and go to school, and actually he graduated with high grades in his third year of college and doing fantastic. So, okay, and this is just one of my patients. What happens is these infections are like layers of an onion. You peel one, you wind up seeing the next infection, and that's what you got here. So you see those lines on him. He didn't have it a few days earlier, but he starts getting treated with antibiotics, and then the lines start coming out. Okay. Tick-borne disorders in kids, and I know I got to finish and go fast, can affect them, though, in every single way that is important for life. It affects them emotionally, as I showed you. It can cause all these disorders. It affects them physically. You know, if your joints hurt, you're not going to be able to do sports. You can't do sports. You're not going to learn the give and take. It can affect them cognitively and socially. You know, who wants to play with somebody who complains he's tired all the time? And when they did a study with the CDC in New Jersey, they found that these kids missed a lot of school, had a lot of, homebound instruction, had a drop in grades. Not a surprise. And so often they need the IEPs and the 504s. Remember that this disorder has intermittent exacerbations. So the kid may look great, but unless he's really cured, you may have another one of those episodes where you can't give him homework because he can't think. Okay, so just when do you consider tick-borne illness? As I said, it can cause anything. But a kid with intense school refusal, I see it all the time. Kid where academics decline for no good reason. And remember, on the testing, look for processing speed and working memory issues. Or a kid who suddenly is going to the nurse's office all the time. That makes sense. The nurse say, what'd you do recently? Do you guys go hiking a lot or whatever in the woods? Headaches. And one other thing. Failure to make the appropriate gain in height and weight. Because, kids grow every year. These kids don't, at least sometimes. And that's because the bugs are competing for the minerals and vitamins. Okay. If you get a dramatic emotional behavioral change in a kid who was perfectly fine before, please keep ticks on your radar. If you have a kid that was fine and suddenly winds up having like 3 psychiatric hospitalizations in which they are not responsive to the usual psychiatric drugs, wonder about tick-borne disorder. Okay. So as I said, you have to think of it with new onset of symptoms or in kids who've had these problems chronically. But when it comes to tick-borne illness, if you don't have an index of suspicion, if you don't have it on your radar, you're not going to see it. And it was the great philosopher Yogi Berra who said, if I didn't believe it, I wouldn't see it. And if you don't believe that tick-borne disorders can cause these things, you will miss it. And that's all. Thank you. Okay. Dr. Bransfield.
Let's see. Close out of this. Hi, thanks for coming out, everybody. Okay, so I'm a local person. I live in Holmdel, and I've been in Monmouth County quite a while here, and I specialize in treating treatment-resistant psychiatric illness. So that's how I ended up involved with Lyme disease. So let me start with 3 basic questions. Where is Lyme disease a problem? How is it a problem? And what can we do about it? So where is it a problem? If you look at it, this study looked at 4,200 studies, epidemiological studies throughout the world, and found that throughout the world, the average was 14.5% of the world population shows seroreactivity to Lyme disease. And that's for the poor quality tests. So it's basically everywhere. And some areas it's worse than others. If you look there at the Northeast, at New Jersey, we're in a hot spot. And if you look at, this was an insurance study. In 2017, New Jersey was #1. In 2021, we were #1. I would rather we be #1 in Big Ten football. But instead, New Jersey is #1 with Lyme disease. So we have to deal with the hand that we're dealt. So let's look within New Jersey, and we can see that Monmouth County is a hot spot. So practicing here, I can't get away from Lyme disease. I just keep getting more and more referrals, and we see a lot of the symptoms that were described. Fatigue is usually the #1 symptom that's most disabling. A lot of people don't understand fatigue. It's lack of energy unrestored by rest. It's different than sleepiness. But also the psych symptoms are significant. Now, this is a study I did where I took 100 of my patients who clearly had Lyme disease and looked at what the symptoms were that they had. My average patient is usually 9 years post-infection when I see them. And these were the symptoms. Now, the average patient, before they were infected, had 4 symptoms. And I look at 270 different symptoms. The average medical student at Rutgers has 4 symptoms. But the average Lyme patient, after infection, has 82 symptoms. So it's like a shotgun blast that affects everything. It's cognitive, it's emotional, it's general medical, and it's a lot of the things that Dr. Greenberg and Dr. Marke had described in their talks. So in children, it's hard often to assess children because, especially if they've been sick for a while, they don't know what normal is. And I'll ask about a pain, and they say, well, of course, doesn't everybody have that pain? And they don't have the baseline, or it may be there so long that they forget, and they're not good at necessarily looking inside their bodies and describing it. So it's often difficult sometimes getting a history. And we
we can look at the mind-body interaction. Now, this is something, a good clue is that it affects the entire body, so it's a multi-system illness. And a lot of people confuse this with psychosomatic, and there's a lot of misinformation about what the mind-body interface, and when something is an illness that affects the mind and the body, or something in the body that affects the brain, or something in the brain that affects the body. Or also the issue of medical uncertainty. And a lot of times, like the three of us are psychiatrists. Why did you end up with 3 psychiatrists today? A lot of times when something's unknown in medicine, then they say, well, that's probably psychiatric. And as long as a disease is controversial and poorly understood, it's referred to psychiatrists. Once people figure it out and get a good handle on it, then we stop seeing these patients. But part of it also is because there's a lot of neuropsych symptoms. So a lot of these people said, well, it's all in your head, or they come up with a lot of weird terms like bodily distress disorder, or the diagnosis is medically unexplained symptoms. And a lot of these phrases have been refuted over time, but that's what we're dealing with. This is a cartoon that I came up with 25 years ago, and the sad part is it's still true today. But this is basically what happens. There's a lot of hidden symbolism in here, but basically we have a patient who describes a classic history of Lyme disease, and he's caught in this triad where people in academic medicine say, well, the proof isn't solid enough, so we're just not sure. And then you have the insurance companies that don't want to pay. And then you have the doctor that says, well, your test is negative, so you don't have Lyme disease. And the patient is a classic case of Lyme disease, and these people feel lost. So when they have this, then it's quite absurd, but it's the way some people think. And I think our algorithm type of medicine that's being practiced now and a dominance of insurance protocols has contributed to this. Right now, there's a good 470-some journal articles showing a connection between Lyme, tick-borne disease, and psychiatric illness, and 86 showing an association with dementia. The American Psychiatric Association has guidelines where they recognize, consider Lyme disease in your diagnosis. However, the Infectious Disease Society of America had this bizarre way of calculating things, and they said, well, Lyme does not cause psychiatric illness. So that's what we're up against. So a lot of times a person gets this confusing illness, they don't know what to make of it, their family doesn't know what to make of it, the doctor doesn't know what to make of it, and our bureaucratic organizations do a poor job, and a person feels lost. So now what I want to talk about, I'm going to talk about the more serious symptoms, which are with fatality risk. And I'll be talking about the suicide first, and then homicide and violent risk. I tend to get the phone calls, because I've done journal articles in this area, when there's someone who commits a suicide or a homicide or an assault, or somebody's in jail, or there's a school shooting, or a church shooting, or a stabbing, or family homicide, suicide. I get the calls from these people or the defense lawyers, and it's distressing to get these calls, but it's a reality what we're dealing with. So most Lyme patients are not suicidal or homicidal, but since there's so many people infected, and there's a certain percent, in my one analysis, I found that 20% of the Lyme patients I see were suicidal, but only 1% were homicidal. But that 1%, when you add up the numbers, that's a large number of people that are involved. And out of those, I did a study of 50 homicidal Lyme patients, and out of those homicidal Lyme patients, 98% were also suicidal. So this is a type of history of what may happen with suicide, where a person gets Lyme, someone misses the diagnosis, they're not adequately treated, and in this case, it was a period over 10 years. Their symptoms kept increasing, and they were frustrated by their symptoms, but they also had symptoms that were contributory to increasing suicidal risks, such as difficulty enjoying pleasure of life, being sensitivity to sound. They were constantly irritated, intrusive thoughts, mood swings, explosive anger, intrusive suicidal thoughts, guilt, crying spells, sleeping off, and neurological symptoms. And then they found one of these suicide kits on the internet. It's rather scary what people can find on the internet about how to kill yourself, and even buying suicide kits. You can buy suicide kits on the internet. And he had this suicide kit, and he committed suicide. Another case is this, which is some artwork of someone. It's a young person who committed suicide. But if you look carefully at that, look at the picture on the left. Look at that person's self-image. Look at the body image. Look at how wasted their body is. And look at what's inside their head. So if that's what a person's struggling with, it's rather understandable about the torture that some of these people have. Now, not every person with Lyme has this, but a certain percent do. And we have to identify those people that are at risk that have this. And a lot of times people aren't too quick to talk about this. Another issue is overdoses. And a lot of times what happens is a person, they get infected in childhood, and then the pediatrician may miss the diagnosis, or they may do this. There's this belief system of one dose of doxycycline, which is totally outrageous. And I think it's a very dangerous thing. And then they're either misdiagnosed or not treated or undertreated. And then they get anxiety, sleep problem, pain. And then someone gives them a Band-Aid type of treatment with a Xanax, a Valium, a pain med, or a sleep aid, and meds that can be what we would call potentially abuse. Then they gravitate towards abuse. They may turn to alcohol or marijuana, and I think this legalization of marijuana, I see a huge amount of it. I had a patient the other day, and they had 10 psychiatric hospitalizations for becoming psychotic from marijuana abuse. And it's like, why did it take 10 for you to realize to stop doing that, okay? But at least they realized after 10. And there are local fatalities associated with this, with all three of these areas, with both overdoses as well as the homicide and suicide. So the overdose deaths, that can occur, and a lot of times it accelerates, and then they gravitate towards the opioids. What normally happens is they try to give it up, and they're away from it for a while. They have an argument with the boyfriend or the girlfriend, and then they go back to the dose they used to take. They don't have the tolerance to it, and they're discovered deceased, and everyone is surprised. So is there hope for these patients? Let's look at that by trying to understand it. We really need to look at this the way they look at an airplane crash with the National Transportation Safety Board, where you try to understand, when there's one of these tragedies, you try to understand, how did it happen? What can we do to change the system so it doesn't happen again? Rather than just putting someone in jail or suing someone, that isn't really corrective action. So to understand it, we have to look at disease, and all the simple diseases have already been figured out. Now we're dealing with these complicated diseases. So there's a genetic vulnerability that some people have and some people don't have. And that's true with any infectious disease. We saw it with COVID, we see it with Lyme. And then there's environmental triggers, and then there's infections. And there are a large number of different infections that we might consider. And then there's this time sequence that occurs where then there's this infection, there's a trigger, there's a cascade. It's like a domino effect and a vicious cycle of how then there can be progression of disease. So this is a picture that I made. So you can think of the infection or some other environmental contributor, and then you have the immune reaction or the lack of immune reaction. The immune reaction can then cause the symptoms. The symptoms make someone stressed, that makes them more immunocompromised, and then it's a vicious cycle that keeps going. So you have to look at those three areas: the infection, the immune reaction to it, and the symptoms. And this is a multi-system model of looking at this. So we have to look, this is a way, you have to, with complicated disease, there's not just one cause. There's multiple causes, and you have to look from the different systems. So it's a multi-system approach where you're looking very small to the very large. What are all the contributors? And it's not just the things that push you that way, but it's also things that deter you. So you want to do a multi-system assessment. What pushes you that way and what deters you, and what is the balance? Now, looking at that with suicide, this is the list that I came up with. So every suicide is different. Every homicide is different. You have to take a balance of all these things and do an assessment. And that's a big part of doing suicide risk assessment, is looking in all these areas. And it's rather complicated, but you commonly see repetitive patterns. So there are a number of infections that increase suicidal risk. And a number of these are tick-borne diseases, but also other infections. So it has to do with a certain biochemistry that occurs that can make someone more at risk from a physical standpoint with a change of the brain chemistry. Last night I was working on a journal article, and it's a case of someone who had Lyme disease. They missed the diagnosis. It went on a good 10, 15 years. They gravitated towards substance abuse, and then they committed a couple assaults. They committed a homicide and committed a suicide. And we're looking at the autopsy findings and the brain tissue and findings, and we're finding Borrelia within the body that was contributory, and we can explain the biochemistry. And it's sad that we have to do that, but that's how we learn this. And that's absolute proof of how these things occur. So when someone's suicidal, there can be a psychodynamic effect where this doesn't make sense. You shouldn't be so sick. It's all in your head. Just pull yourself up by your bootstrap and you'll be fine. That's what I do. It works for me. It should work for you. And then there's that physiological risk that there's a biochemical risk that's there that has to do with how these infections affect brain chemistry. So why do people commit suicide? And this was a survey with people that had Lyme disease, and they say hopelessness or lack of educated doctors, isolation, debilitating symptoms, feeling like a burden. Lyme causes depression, watching our friends die. They're often in these support groups, and they see other people that commit suicide or die from the disease. And when you look at suicide, you have to look at the degree. Like, is it a passing thought? Is it a recurrent thought? Is it preoccupation? Are there plans? Are there impulses? Are there attempts? Are there well-planned attempts? And that's very different than people that are self-destructive, that are superficial cutting. That's self-destructive, not necessarily suicidal in the same way someone who wants to kill themselves. So when we look at that, we look at, there's an article I did where I looked at suicidality. I did it 5 years ago, and I looked at all the different components to it. I looked at 250 patients and did some of the math. Suicide in the United States are around 48,000 cases, and 14.1 is the suicides per 100,000 in young people. So you do see suicides in young people. It did increase during the pandemic. I think the pandemic was catastrophic in that people were more isolated, and a lot of at-risk people were impaired, and I think a lot of young people lost 2 years of social development, even if they were keeping up with their studies. So recently, we've seen this flood of suicidal young people in emergency rooms. And this was a recent article, was in the news last week. And different hospitals are reporting this. We also had, during the pandemic, there were a lot of suicidal young people that were sitting in emergency rooms for days because we couldn't find a bed. The hospital system was so overloaded. But we're still seeing that. We're still seeing this increased amount of suicidality. So how common is Lyme and suicide? And basically, I'm not going to describe the math, but my calculation where there's probably 1,200 suicides per year related to Lyme and tick-borne disease. And Dr. Fallon also did a study that was described by Dr. Greenberg, and in that study, he did a very different analysis where he looked at Denmark, but when I figured out the math, his numbers came out about the same as mine. So it's not the number one cause of suicide, but it's one suicide is too many, and 1,200 per year is far too many. And this is something that could be prevented. So we want to do everything possible to try to prevent it. And when I looked at, I've treated thousands of Lyme patients, and when I first, in practicing in this area, and I got my first Lyme patient, I thought, well, where can I send this patient? Who knows something about Lyme disease? And there was no real place to send them. And Dr. Fallon, who's up in New York, and myself, we were both dealing with this, but so we just had to figure it out ourselves as best we could. So these were the different deficits when I did my analysis. When I looked at my patients with Lyme who were suicidal and compared it to the patients who were not suicidal, I saw this pattern of symptoms that the ones that were suicidal had a cluster of symptoms that collectively increased their suicidal risk. So I came up with basically what was called a death formula. Now this is more physical. So this is that when you get an infection, and you see this with other infections too, it increases inflammation in the body. Ideally, you get infection, and then you get inflammation and adaptive immunity, and then you're fine and it's over and done with. But with these infections, you don't get that. Instead, you get persistent inflammation. It's like being stuck in first gear, and you never get shifted into second gear. You may get autoimmunity, and then that persistent inflammation shifts the way the brain processes tryptophan, and tryptophan's an essential amino acid. It should go to serotonin. So then a lack of serotonin is associated with suicide, but instead of going to serotonin, it ends up as quinolinic acid, which is a neurotoxin. And in the case I was talking about, we found quinolinic acid in the brain of that patient who committed the suicide and homicide, and that shouldn't be there. So that is something that makes someone more violent, suicidal, and homicidal on a physical basis. So, and this was Dr. Fallon's study. He found, that was mentioned before, he found basically similar things. There's a strong correlation there between Lyme disease and suicidality. So it's really absurd when the Infectious Disease Society of America says that Lyme disease does not cause any psychiatric illness. It's beyond comprehension. So so I want to talk about bullying for a minute. That's something that comes up. Now, think of it as our brain, think of it as a product of evolution. We have the lower part of our brain, the brainstem. We could call that the reptilian brain, the mammalian brain, and the human brain. And dominance struggles is a part of mammalian behavior. However, the civilized human brain keeps that in check. But when there's brain damage, it doesn't keep that in check. So just like you see this dominance behavior in animals, then you can see that emerge in people, and you see the bullying. So when you see the bullying, there's two sides to that. What's wrong with the person who's doing it? Why is their aggressiveness not adequately kept in check? That's one part of the problem. And what about the victims? What happens to the victims? So if we look at that, if we look at the victims, people that have been victims of bullying often have autoimmune diseases later in life. And so they're often, it puts them in a state of chronic stress, and not only infection, but also chronic stress can push someone towards that chronic inflammatory state that's associated with a lot of chronic illnesses, increased cancers, increased general medical problems, a long list of things. Now, another area similar to that is not just the bullying, but the adverse childhood events. And that's a significant thing to look at. And adverse childhood events could be neglect, abuse, death of a parent, or criminal behavior, et cetera, in home. And the more you see adverse childhood events, the more you see adult illnesses that have immune effects. And so there's a connection there with that, post-traumatic stress disease and infectious disease. So I came up with this formula that helps explain it. So think of it like this. Ideally, when you have a danger, internal in the body, the immune system recognizes this is dangerous. Let's do inflammation, adaptive immunity. We'll deal with this threat, and now we're good. We've adapted. That's what should happen. Likewise, environmentally, if I say, okay, there's a hazard, let me be careful, now I know what to avoid, and now I've adapted to it. However, autoimmune disease, in many ways, is like post-traumatic stress disorder, where you're presented with a hazard, but you're not adapting to it appropriately. So autoimmune disease, the body ends up with friendly fire fighting itself. And with post-traumatic stress disorder, you're overreacting to something you don't need to react to and often underreacting to something that you should react to. So there isn't the adaptation to danger that there should be. And there's often crosstalk between these two systems. So people with autoimmune disease, there can be an overlap with people with adverse childhood events and post-traumatic stress disorder. Now, intrusive symptoms are something I want to draw attention to. It was mentioned before, but this is quite unusual. We see this with obsessive compulsive disorder, post-traumatic stress disorder, and Lyme disease. And it can be associated with overactivity in the temporal lobe. And people don't always volunteer this, but whenever I give a talk on Lyme disease and I talk about this, I see a lot of people nodding their heads that they can relate to it, but they're too self-conscious to talk about it. So it can be an image of like a horror movie, or it can be a horrible thought that's contrary to something you would normally do, something you wouldn't want to do, of things that that you say, well, do this, and oh my God, why am I thinking that way? So intrusive symptoms I found in 34% of my patients, and you see it, as I said, with OCD or post-traumatic stress disorder. And it goes with immune activity, and when we can tamp that down, we can reduce it. Now, to talk a minute about violence, we can get intrusive, aggressive thoughts. Now, these are some of the things that people have said to me. I had intrusive thoughts of killing women with a knife or an axe. Then some mechanism in my head was telling me, kill her, kill her. Sometimes I had thoughts of killing my sister's one-year-old child or my mother. And these are thoughts that just come. Now, a lot of people then struggle with that. I think some people commit suicide when they have these thoughts because they're so scary, they're afraid they're going to act on them. Or another patient, this was, the patient had aggressive and homicidal urges contrary to her normal personality. She was in a local restaurant, and she looked at someone across the restaurant and had this urge that she wanted to attack that person, and she didn't understand why that occurred. I had a patient who did that, and she attacked a garbage truck. She went after the garbage man, and she was in a violent rage and didn't understand it. Or another patient who he described intrusive, overpowering thoughts. Now, in his case, it was triggered by a dog barking or stimulation or too much commotion or bird chirping or light. And then he said he had episodes of anger and an urge to destroy and a sudden urge to kill and everything, rip the room apart and kill every living thing and every animal. So they often have this urge to kill the house pets in addition to everyone who's alive. This is an example of, so there's things called family homicides, and I've dealt with this for a long time in the aftermath of it. And you see where someone just goes berserk and takes out the family and themselves, and then there may or may not be some survivors. And a lot of the cases with Lyme, they also kill the dog. And these are examples of two cases where they killed the dog as well as their partner and then themselves. Here's a case that was in a newspaper. Now, we were talking before about Bell's palsy, where there's a crookedness on the face, and you can see that here on the father's face. This was a family where they went to the trouble of getting a heart transplant for that infant. And then all of a sudden he went berserk and killed everybody, including the dog and himself. And it was puzzling why that occurred. Now, it would be nice to prevent these things and to understand them. Not all of them are from Lyme disease, but I think with what people describe to me, I hear people on the brink of doing this and people that we hospitalize, and whenever you prevent these tragedies, you don't hear about it. You only hear about the ones that we don't prevent. So I did a study where I looked at homicidal patients who had Lyme disease, and there's three kinds of homicide. There's impulse control disorder, there's psychotic, and then there's predatory aggression. Now, the impulse control disorder, you could go to any hospital emergency room on Saturday night at 2 a.m., and you'll see these cases come in. And sometimes alcohol is a part of it, and one thing leads to another, and the person loses control. Those are the most common things that we see, and we see that, and a lot of the aggression that I see with tick-borne disease is bizarre and senseless. It makes no sense. It's not like the brilliant Ocean 11 crime that's well planned. It's like, why would someone do that? It makes no sense at all. That's the usual case that I would see. But sometimes they're paranoid, where a person feels that they're out to get them, and they feel that they have to do something to protect themselves based on delusional thinking. And the third area is predatory aggression, and I've seen this as well. And this is what you see with more, like, I see this with people that have more serial killer type traits, where they seek out, they stalk, and they plan it, and it's almost like that predatory animal instinct. And these people that have this, when you're talking to them, you don't have the bond that you get with a normal person. It's like they look at you like you're an object. They lose a sense of human connectedness from a temporal lobe damage that these people have. If you do brain imaging, you can find it. And if you look at, let's say, people on death row, and this is the kind of person you'll probably see on death row, 100% of people on death row have a history of brain injury and a history of abuse. So not all these people is it Lyme disease, but Lyme or these infections, sometimes you see it with herpes, infections can damage that part of the brain that contributes to predatory aggression. So there's also a physiology similar to what I described, and think of it like this. Your brain, there's a part of your circuit that says attack and a part says restrain. It's the imbalance of the two. So we use a formula just like with suicide. What are the contributors? What are the deterrents? It's the balance between the two. And these are the contributors that you think of with violence, aggressive behavior, or homicide. And these are the different infections that we associate with aggressiveness. So we think of this formula. There's contributors, chronic, and then acute, and then there's failed deterrence. And then when those things interact, you can get violent behavior that sometimes can be fatal. So this is the formula that I came up in analyzing my homicidal Lyme patients. That list of contributors, the number one was being suicidal, and then the failed deterrence and acute triggers. So looking at this further, I had a hypothesis that, wait a minute, this isn't just a local problem, this is a global problem. So if you look at, let's say, World War I, there were a huge amount of infections in the aftermath of World War I. And my concern there was probably that caused a lot of brain damage in a very large number of people. And those people that were brain injured in World War I then became leaders and played a role in contributing to World War II. And now if we look at this picture, what do these people have in common? Okay? What they all have in common is there's different degree of evidence they had infections, be it syphilis or otherwise, that affected their brain and contributed towards aggressive or violent behavior. And a lot of times what you see with people that have this trait is at first they're ruthlessly brilliant when they're younger because they have no empathy. They do things that no one else would ever consider. But then as it progresses, then they get more demented and they do stupid things. Now, we can see that there's certain parts of the world that are more at risk, that are more endemic to violence because of local infections. This is an example of Afghanistan. These are the tick-borne, vector-borne, mosquito-borne infections in Afghanistan. And there's also these other infections. So maybe you can never correct the violence in an area like that unless you use the public health approach. That's the only thing that would do it, not a military approach. So this is a presentation I gave in Paris in 2017, right before the pandemic. And I said, we better not have a pandemic that causes mental problems because that could cause global instability. Now, unlike that famous list of bad guys that I showed you, now we have nuclear weapons, okay? What if those people had nuclear weapons? So that's the case now. So when we look at this, there's these risk factors, but we can treat it, we can do something about it. And the treatment is a similar way, where we look at what contributes to the infection, how's the immune system not working properly, and how do the symptoms occur. And that's where we can intervene. So before I mentioned that as psychiatrists, we often are like the safeguard with the healthcare system. But as teachers, as school people, I think you catch the problems that exist in society. This is a great slide where it shows all the problems that many a child's life and has been saved and salvaged by an alert person in the school system who caught a problem and intervened and prevented a catastrophe. So we can prevent it by better recognition, better treatment. It takes a bigger approach. There was a recent report to the Congress, the Tick-Borne Disease Working Group, where they recommended the mental health part of it, and that was significant that they were able to do that. It's available on the internet. And so recovery is mastery over adversity. We need to be able to predict risk. It's like walking through a minefield. You have to know where to step and where not to step, and we need to be vigilant. So there is think of this number, 988. That's a suicide hotline. You want to put that everywhere. There's also the Columbia Suicide Assessment Scale that you can download on the internet. And at the bottom there's pending legislation in New Jersey for suicide prevention with schools. So back to the question of, is there hope? Yes, there is hope. Now that old picture, that depressing picture that I showed of the good ship Hope, which was an old Liberty ship that was being taken apart, it's now replaced by a fleet. So that's what it takes, a fleet. It takes a group. And I think the comment about Dr. Osler saying, if you know syphilis, you know medicine. But to know Lyme, you have to know more than medicine. You have to know ecology, entomology, you have to know veterinary medicine, you have to know immunology, you have to know psychiatry, you have to know economics, politics. You have to know a very broad range of things. And that's part of the problem, is that people use a silo mentality and they get stuck in their turf and they don't connect the dots. That's what we have to do. So there is hope. We can do things. Suicide is a permanent reaction to a temporary problem, and people can go on to live rewarding lives. We can prevent it. We can do things. And knowledge is empowering. As educators, we can all relate to that. So thanks for your attention. And now I hope we have time for a question and answer. Do you see much Lyme disease here? You know, I can't get away from it. It's here. And we don't always catch it. And is it increasing, or is it partly, it's always been there, but we called it other things? I think that's part of it, but I think there's some environmental change that's increasing. So do we have time for the three of us for any questions, or I guess we're right on time? Okay, any questions? All right, well, thanks for coming, and it's, I think, you know, it really makes a difference when we can catch these things and prevent them. All right, thanks.
Thank you very much, everybody. Thank you, Dr. Cascone, for making this available for us to present here. Thank you for each physician to coming and talking. You're sharing your expertise and your time. Thanks for everybody that attended. I hope you find it beneficial. I do know, in talking with Amanda and others here, that on paper, Holmdel feels in the school system they have very few cases of Lyme in the school system. I think that as you look at some of these other symptoms, that if you look at those, that you may find that some of the things that are being mimicked may actually be as a result of Lyme or a co-infection, what I call a vector-borne illness. It doesn't have to be just from a tick-borne tick bite. It could be from in utero. It could be a flea. It could be a mosquito bite. There does not have to be a rash. There does not have to be a circle. There are a lot of variables. But I hope this helps you in what you do, at least for enlightening a little bit, so that you can be aware of this. Awareness is key. And I hope it perhaps helps somebody you might know, whether it's a family member or a neighbor or something like that. I live in Holmdel. I live on a street that has 16 homes on it. We each have maybe a third of an acre. Deer are walking around all the time, rabbits, foxes. Recently fenced my backyard in to keep the deer out because my grandson plays back there. But out of the 16 homes a few years back, 8 of those homes were affected by Lyme disease. So I do believe it's much more widespread, and we just don't know about it, or a lot of people don't know about it. So thank you for your time. I'm not a physician. I run the New Jersey Lyme and Associated Diseases support group. And so I'm really just a conduit. So if you have a question later on and you want to ask me, I may be able to direct you to a wonderful physician. We have wonderful Lyme literate physicians in New Jersey. And that's that. So I hope all this helps. Thank you for your time.